Okay, picture this. A 55-year-old guy stumbles through the ED doors. He's clutching his chest, he's drenched in sweat, and he's visibly struggling to breathe. Right now, there is absolutely no time for second-guessing. You're on the clock. Your clinical decision tree begins the exact second you read that vignette. So let's map out the dark mode test day logic for Step 2 CK cardiology.
Moving right into ED chest pain, triage, and initial branch logic. Boom, you drop straight into triage mode. Secure venous access, get those vitals, order a chest x-ray, and if your concern for an aortic dissection is distinctly low, you give aspirin. Your mental algorithm has to instantly branch out into the major critical buckets. Are we looking at a STEMI, an NSTEMI, or unstable angina, maybe a pulmonary embolism, pericarditis, an aortic dissection, or a totally non-cardiac cause? Honestly, the decisions you make in these first few minutes, they literally dictate patient survival and, yeah, your board score too.
Let's dive into the branching logic for our stable patients. We're separating them out by low, intermediate, and high pretest probabilities for coronary artery disease. If a patient is stable, falls into the intermediate risk category, and they can actually exercise with a normal baseline resting ECG, well, an exercise ECG is your path forward. But what if they can't exercise, or their baseline ECG is completely unreadable or abnormal? Then you shift gears to a pharmacologic stress imaging test. And remember this, if their pretest probability is extraordinarily high right off the bat, you might just bypass stress testing entirely and go straight to coronary angiography.
But let's rewind a second back to the acute setting. Pause right here. What is the absolute best initial test for chest pain?
The answer? It's the ECG. We all know the saying, time is tissue, and this foundational step absolutely must be completed within 10 minutes of arrival. You're hunting for ST elevation in contiguous leads. You've got to remember your exact thresholds here. Generally, it's 1 millimeter, but in leads V2 and V3, you need 1.5 millimeters for women, 2 millimeters for men over 40, and 2.5 millimeters for men under 40. Oh, and keep in mind, any new left bundle branch block presenting with ACS symptoms, you treat that exactly like a STEMI. And hey, if the first ECG is non-diagnostic but your clinical gut feeling remains high, don't just stop there. Order serial ECGs and repeat those troponins.
Now, once that unstable track branches based on the ECG, you're going to rely heavily on cardiac biomarkers. Troponins elevate within hours and can stay elevated for up to a week. That makes them the absolute gold standard for your initial diagnosis. On the flip side, CKMB normalizes much faster, which makes it the superior marker for catching an early reinfarction. Your test day logic requires you to know exactly which marker answers which specific clinical question.
Okay, let's test a classic Step 2 CK medication trap. Pause here. What pharmaceutical treatment should be completely avoided in patients with an MI who also present with congestive heart failure or bradycardia?
Beta blockers, that's your answer. Now, while beta blockers are great because they decrease myocardial oxygen demand and limit infarct size, they are absolutely contraindicated in cardiogenic shock, acute heart failure, and severe bradycardia. And since we're talking about test day traps, let me give you another one. Avoid nitrates if the patient has hypotension, a right ventricular infarct, or severe aortic stenosis. Giving nitrates there will dangerously bottom out their preload, and you definitely don't want that.
So when it comes to initial STEMI stabilization, precision is everything. You only provide supplemental oxygen if their SAT is below 90% or if they're actively dyspneic because we want to avoid oxygen toxicity. You administer aspirin, a P2Y12 inhibitor, a high-dose statin like atorvastatin 80 milligrams, and anticoagulation. But remember, the clock is ticking on reperfusion. PCI is heavily preferred, ideally within 90 minutes of first medical contact. But what if you're stuck at a facility where PCI is unavailable within 120 minutes? You've got to immediately pivot to fibrinolytics.
Let's pivot to a really specific, high-yield differential presentation that perfectly mimics standard ACS. Pause here. What is the treatment of choice for agitation in an NSTEMI patient presenting with chest pain, dilated pupils, and completely normal cardiac enzymes? IV benzodiazepines. The massive key clue here, those classic clinical features of cocaine use. The intense sympathetic hyperactivity is causing extreme coronary vasoconstriction, and that requires IV benzos to calm the central nervous system. A standard ACS protocol just won't fix the underlying toxicological drive going on here. Plus, throwing a beta blocker at this alone could actually lead to unopposed alpha receptor stimulation, making things way worse.
All right, let's look at how this builds out our NSTEMI and unstable angina risk stratification. We use the TIMI risk score to map out our next move. Low risk, they get a stress test. Intermediate or high risk, they need early coronary angiography within 24 hours. However, if they have hemodynamic instability, new mitral regurgitation, clinical heart failure, recurrent chest pain despite maximal medical therapy, or dangerous ventricular arrhythmias, they skip the line completely and require immediate angiography.
Let's test your diagnostic restraint when managing a patient way down at the bottom of the risk pool. Pause here. What is the recommended diagnostic test for patients with chest pain that have a distinctly low risk for CAD?
No further testing for CAD. I'm serious. Overtesting is a massive trap, both on test day and in the real clinical world. If they are truly low risk based on their history and initial presentation, you stop the CAD workup right there. Instead, you need to explore other non-cardiac pathologies, things like GERD, musculoskeletal pain, or even a panic disorder.
Right, moving into the dangerous territory of right ventricular MI, key differentials, and post-MI complications. You've got to remember that up to half of inferior MIs actually affect the right ventricle. You confirm this by looking for ST elevation in the right-sided lead V4R. Clinically, you're looking for the triad of clear lungs, JVD, and hypotension. Now, these patients are highly preload dependent, so your move is an IV saline bolus, especially if they have low or normal JVP. And you absolutely must avoid any preload reduction, so no nitrates, no diuretics.
Let's introduce a catastrophic differential that shares chest pain symptoms but needs a completely different approach. Pause here. What is the likely diagnosis in a patient with an aortic dissection that suddenly develops hypotension, JVD, and pulsus paradoxus?
Cardiac tamponade. What's happened is the dissection has likely ruptured retrograde into the pericardial space. Nailing down that exact clinical triad, Beck's triad, is crucial. But on an ECG, seeing electrical alternans paired with sinus tachycardia is highly specific for a massive pericardial effusion leading to tamponade. Your immediate next step here is getting an echocardiogram and performing pericardiocentesis.
Let's check your knowledge on another life-threatening chest pain differential that also presents with right heart strain. Pause here. What ECG findings are classically associated with a pulmonary embolism? S1Q3T3, meaning you'll see a prominent S wave in lead I, a Q wave in lead 3, and T wave inversion in lead 3. This is a classic high-yield board indicator of acute right heart strain. But keep this test day logic in your back pocket. While S1Q3T3 is the classic clue you have to recognize, simple sinus tachycardia is actually the most common ECG finding you'll see with a PE.
Now let's talk about the long-term structural fallout of an infarct. You have to know the physical complications. We're talking papillary muscle rupture, causing acute severe mitral regurgitation, a ventricular septal rupture that presents with a harsh hollow systolic murmur, and a free wall rupture that leads to fatal tamponade. Medically speaking, your post-MI management has to be absolutely airtight to prevent these structural disasters. The regimen is dual antiplatelet therapy, a beta blocker, an ACE inhibitor or ARB, and a high-intensity statin. Plus, you add a mineralocorticoid antagonist if they have an ejection fraction under 40% combined with either heart failure or diabetes.
All right, what about the immediate post-infarct period? Pause here. What is the most common cause of sudden cardiac arrest in the immediate post-infarction period?
Reentrant ventricular arrhythmias. Specifically, we're talking about ventricular fibrillation. This is the silent killer you have to continuously monitor for in the hours right after a massive infarct. The ischemic tissue creates this super unstable electrical substrate, which makes those lethal reentrant loops highly likely.
Let's take a scenario outside the hospital walls for our final recall question regarding adult cardiac arrest. Pause here. What is the single most important factor for survival in an out-of-hospital sudden cardiac arrest? Elapsed time to effective resuscitation. It's really that simple. When you're managing adult cardiac arrest, you must immediately distinguish shockable rhythms, like VFib and pulseless V-tach, from non-shockable PEA and asystole. For those shockable rhythms, you emphasize continuous bystander CPR, prompt defibrillation, epinephrine, and you push amiodarone after the third shock. For non-shockable rhythms, you rely on CPR and epinephrine. And for all arrests, you have to immediately hunt for the reversible causes, those classic 5 H's and 5 T's.
Let's wrap this all up with a rapid-fire algorithm finish for the rest of your cardiology test day. Ready? For symptomatic bradycardia, push atropine first. If there's persistent instability, get to temporary pacing. For tachyarrhythmias with a pulse, if they're unstable, immediately do synchronized cardioversion. If they're stable, well, a narrow and regular SVT gets adenosine and vagal maneuvers, while AFib or aflutter gets rate control. What about AV blocks? First degree and Mobitz type I generally just need careful observation. but MOBIDs type 2 and third-degree blocks, they require a pacemaker. Finally, if your patient flips into acute decompensated heart failure, slap on oxygen or NIPPV for respiratory failure, use inotropes if they're actually in shock, push IV loop diuretics and vasodilators when it's appropriate, and then immediately investigate the underlying triggers. That is your dark mode step 2 cardiology decision tree. Lock it in.